Clare Fowler, thank you so much for joining me this afternoon. You're the lead breast cancer consultant in Gloucestershire. How long have you been in post?
I was appointed in 2004, so I've been working as a consultant for 11 years now.
Lots of experience then.
Yes.
The UK does lag in our cancer outcomes compared to other countries with comparable healthcare systems, but breast cancer is a good news story, isn't it?
Yes, we've closed that gap quite significantly, but there's always more we can do.
Always room for improvement.
Yeah.
There is a current Be Clear on Cancer campaign aimed at ladies over 70 to come and see their GP with any concerning symptoms or signs. Could you summarise what we might see in our surgeries, what are ladies being encouraged to come with?
I think that these women should be encouraged to look and come if they notice any obvious new lumps in their breasts, any definite blood coming from their nipples, and any new distortion, changing contour in the breast, which they should be aware of. And the best way to see that is by actually standing in front of the mirror with their hands in the air, and that very clearly shows if there's a dimple or a change in that way.
What about pain as a symptom?
We see a lot of women referred with pain. I can safely say that the majority of breast cancers have no pain associated with them. I think that women should be advised to check their breasts if they do notice any pain, and if it hasn't subsided over a few days, then if they're not happy checking their breasts, then maybe they should visit their GP to be sure there's nothing underlying that. But having said that, the majority of women who do get to see us with their breast pain actually have quite often musculoskeletal pain or discomfort that actually is coming from underneath the breast tissue itself. I
think there has been a trial of people using non-steroidal gels to see if that would help decrease the pain. So that's something that we can suggest to people if it's hormonal, trying some primrose oil or something. But as you say, it's not really high up on the list of concerning symptoms.
No, I wouldn't put it very high.
Yeah. So what are the red flag symptoms that we as GPs should not miss?
Anybody with new peau d'orange in the breast, particularly if it's associated with any pinkness.
And peau d'orange is
where the breast,
dimpling?
Yes, it's small, looks like small dimples, like the orange peel, with redness, with no lumps, can on occasions indicate inflammatory breast cancer.
That's caused by fluid, isn't it?
It's fluid that's collected in the breast tissue itself, and you can almost, if you press on the breast, you may get a dimple, like with any edema. Other things that they should be aware of is any distortion in the breast, any new lump in the breast, as we said before, about any definite blood-stained nipple discharge, and any dimpling, the same with the women themselves noticing.
And what symptoms, therefore, can we safely manage in primary care?
Well, coming back to pain, I think that younger women with breast pain should generally be reassured, particularly if their breast examination is normal. I think nipple discharge, we've mentioned obviously that blood is worrying, but I think we see lots of discharge that is green in colour or yellow or creamy, and coming from multiple ducts. Again, is not something that I would be terribly concerned about. The other symptom that people come along with is with nipple eczema. There's a big difference between the nipple itself and the areola, and what people are worrying about is Paget's disease, which comes out on the top of the nipple itself, not round the edge on the areola.
Right,
so I think patches of eczema on the areola, again, are not so concerning.
So that can be treated with some hydrocortisone or
certainly
E45.
Yes.
If it's something that persists after you've given a trial of that, is that something that we should be worried about, or we should just treat it as we would any other eczema?
Yes.
Yes.
In general, if it's on the edge of the areola and around the areola.
Okay.
Yes.
And what about breast abscesses?
Well, breast abscesses, we have a fairly clear pathway set up in the hospital, because either they come through from the GP, or quite often they appear in accident and emergency. And we don't incise and drain them as many abscesses are in the other parts of the body as such. So they have a quick way into our clinics, and they can be added on a daily basis.
So there is a certain way that we can refer in if we do have a suspicion of breast abscesses over a normal breast lump?
Yes.
Is it normally a patient that's had a history of them?
Not always, but if somebody's unwell and got a pink, obvious pointing in their breast, then they need ultrasound and aspiration, and antibiotics is how we treat them.
Okay, that's very helpful. So what about gynecomastia in men? Is that something we should be concerned about?
It's not something to be concerned about, to the extent that now if you want to refer a gynecomastia into the clinic, you need to get funding from the CCG first, and any surgery that was ever going to be looked at also needs funding.
So it's seen as a cosmetic procedure, is it?
Yes.
Okay, okay. What happens if a lady presents saying she wants BRCA testing because her grandmother had breast cancer when she was quite young? What do we do in that scenario?
I think in your specific case of somebody with their grandmother, it's they probably need some reassurance. But in general, with people who say they have a family history, it's getting them to be sure about what the family history is and the ages of any relatives that have been affected. And then the NICE guidelines are fairly clear who should be referred on to secondary or tertiary care for family history consideration. And in Gloucestershire, if they fulfil those requirements, then a referral letter to the geneticists, who then send a pro forma to the patient for their family history, and they work it out from there.
Right, so they don't necessarily need to see everybody, and
No.
yes.
No.
And there's also NICE bites, which are been done on several different topics for GPs, which I really like. There's sort of 2 pages of summary of the NICE guidance and how we should act on that. So that's very helpful, and there is NICE for familial breast cancer. Claire, you're well aware of the national directive from 2010 that mandated that all ladies with symptomatic breast problems need to be seen by your departments within 2 weeks, as well as the suspected breast cancers that we refer in via the 2-week wait pathway. How has that impacted your service?
Well, I think in line with lots of other services, the referrals have increased enormously. Having said that, the number of breast cancers have also increased over the years, and we're now up to over 600 in the county. This is screening and symptomatic ones. But the referrals don't come in regularly every day. Some days we get 30 or 40 referrals, some days less than 10. On an average week, we're looking at about 125. So it can be very challenging.
I've sat in your MGT and going through all that number of patients, it's difficult. Yeah. So what can we do to help you as GPs?
I think looking at what we've just talked about red flag symptoms and seeing what does definitely need to be referred in, and then being sure that the patient is available in those next 2 weeks to be seen. Otherwise, we are penalised, even if somebody's on holidays having been given a referral.
So it's very important that we have that open consultation with the patient and give them one of our 2-week wait leaflets on the purpose of their appointment is to rule out cancer. So, indeed. Okay. Clare Fowler, thank you so much for your time this afternoon.
That's my pleasure. Thank you.
Thank you.